Hello, everyone. Welcome to the AGEM and Behavioral and Psychological Interest Group co-sponsored webinar. Thanks for joining. I'm here with Bernard Chang, who's the co-moderator today. This is our first co-sponsored webinar, and we're excited to create a space to focus on geriatric mental health and well-being, and to collaborate amongst different interest groups and to bring in speakers in this area. Our goal is to have a recurring webinar series with other topics as well, like loneliness and social isolation, depression and suicide screening, and substance abuse. Today, we'll be talking about altered mental status and delirium and geriatric agitation in the emergency department. Bernard, do you want to add anything?
Oh no, this is really excited to kind of have the group here. I think we've got together a really nice, exciting group of speakers as well, kind of some great topic experts, and hopefully it's going to be kind of a really fun conversation with all the participants today. So thank you everyone for joining us.
Awesome. I guess the inspiration for this webinar in general and the collaborative webinar series for me sort of stemmed from taking care of my father and grandmother and watching their care in the emergency department in the hospital, and realizing that as we're adapting to the aging population and just focusing on how we can enhance their care overall and their well-being, and focusing on topics that not always focused on directly. We can go ahead and introduce the speakers and get into the speakers that we have today.
Yeah, that sounds great. So it gives me really great pleasure to introduce Dr. Ambrose Wong, a nice, great, good friend and also a fellow colleague kind of in the space of behavioral health emergencies within emergency medicine. Dr. Wong is an associate professor at Yale University, where he focuses on looking at behavioral emergencies as well as kind of teamwork dynamics such as patient safety, as well as healthcare disparities. He's received, similar to some of our other kind of great colleagues within the specialty, he's received funding at the state, federal level, currently has been funded by the NIH as well as PCORE, really focusing on a lot of his work within behavioral emergencies. So thank you so much, Ambrose, for joining us today.
So next speaker that we have to follow Ambrose Wong is Maura Kennedy. Dr. Kennedy is the chief of the division of the Geriatric Emergency Medicine at Massachusetts General Hospital, an associate professor of emergency medicine at Harvard Medical School. Dr. Kennedy's clinical education and research endeavors focus on improving emergency care for older adults, with specific focus on those with cognitive impairment. She has conducted research into geriatric emergency departments, the detection and management of delirium in emergency department patients, and care of persons with dementia in the emergency department setting. She currently serves as the chair of the Geriatric Emergency Medicine section for the American College of Emergency Physicians, and is on the board of the Governors for ACEP's Geriatric ED Accreditation Program. She's also the past president of the Academy of Geriatric Emergency Medicine. So welcome, Dr. Maura Kennedy. Thank you for joining us. Without further ado, into the speakers.
Yeah, I'm happy to get us started. I'm just going to quickly share my screen. So thank you so much for hosting me and Mara. We're really excited to speak with you all about this topic that we feel very passionate about. And it's really exciting to see sort of us bridging networks and groups within SAEM, folks within behavioral health emergencies, as well as geriatric medicine. And so I think Mara and I today would like to sort of bridge that gap by talking specifically around geriatric delirium, dementia, altered mental status, and agitation, which is a very broad topic encompassing a lot of different subsections. And so we'll try to do it justice by having me go first and giving a little bit more of a general overview around de-escalation, agitation, and workplace violence. And hopefully some of the slides I have will be a good segue to Maura's slide deck that's going to focus a lot more on delirium, dementia, and some of the clinical management pearls that are focused on geriatric delirium and agitation. Yeah, so without further ado, and I just want to give credit also to the Workplace Violence and Agitation Collaborative. Some of the slides are borrowed from our presentation that we gave last year or a couple months ago at the annual meeting. And then we'll go dive a little bit more and try to make a little bit more of a geriatric focus for this webinar. Very quickly, as Dr. Chang mentioned, I have some federal grants fund this related to the research that we'll present. So as I mentioned, the goal of this 20-minute section within this larger piece is hopefully to give some quick updates and evidence-based strategies to think about acute agitation, specifically for this subpopulation of older adults, and also bridging that with thinking about safety for us as healthcare staff and specifically for emergency department staff and emergency department physicians. So the first section, we'll be thinking a little bit about verbal de-escalation, and then transitioning that to thinking about workplace violence prevention from the focus of agitation. So let's talk a little bit about de-escalation first. And this is going to be a really high-level overview and quick move through a bunch of different topics. But before we even talk about de-escalation, I think one thing that for me is a big piece when we talk about wellness and managing patients that are potentially agitated, and this is really a definition of folks that have increased psychomotor activity and take up a lot of resources, is that sometimes for us as emergency physicians, we deprioritize folks that have behavioral health issues. And this is for a number of different reasons. But I think one thing we think about is that there is sort of a sense that the folks that come in with behavioral emergencies are less sick than others, or they're not as medical. And I want to really challenge that notion by thinking about patients with agitation as those that have just as much of an emergency or priority as folks that come in with maybe what we think about more as traditional medical complaints, like chest pain, shortness of breath, or other medical issues. And I think really when we think about de-escalation, if we prioritize them and act on them proactively, that's really going to keep us safe, but also make the chance of de-escalation and management of agitation more successful, patient-centered. Because agitation builds, and I think Mara will talk about this in her slide deck too, really, by the time we detect them to have very overt signs of agitation and agitated behavior, in some ways it's a little too late. They've gotten so severe that unfortunately we have to have some measures that really are not patient-centered and in some ways coercive. So if we can act preemptively and both detect it early, but also proactively work on these patients that have high risk, it really is sort of the best course of action. And in some ways, really, these patients deserve that just as much as any other patient. So in terms of de-escalation, I think before we even get to the point of de-escalation, we want to think about agitation in a little more of a structured, systematic way. And in some ways, really, this area of research is very understudied. How do we define agitation? What are levels of agitation really considered to be at different levels? And we think about stroke scales, or we think about levels of trauma or other things that have had decades of evidence and research to really structure and define these levels. And we really don't have as much of that with agitation, and really specifically around emergency department agitation. And I think the first thing is really defining what agitation is, which I mentioned earlier. It's any evidence for excessive psychomotor activity that can lead to aggressive or violent behavior. And if you think about it, it's very broad because it's really any sense of any potential violence can happen. And I would say that there's a significant amount of subjectivity to this because it really depends on how people perceive that behavior. So before we even think about managing it, I would say that the most important piece is really objectively assessing the behavior and measuring it. And unfortunately, there are no agitation scales. And I would say in the geriatric world, there probably are more so. But if we're thinking about emergency department agitation, there are no scales that are truly validated and created for the emergency department currently. But we can borrow from other scales that are developed in the psychiatry literature and behavioral literature. And I would say to think a little bit about measuring the level of agitation and thinking about designing your strategies to match the level of agitation. And to think about specific scoring scales or measurement scales that help you think about the level of agitation that the person is presenting, and really thinking about geriatric specific instruments when we're talking about older adults, because they present with symptoms and signs that are very different and distinct from maybe the general population in terms of both the etiology and the way that it manifests agitation. The second thing to think about is when they manifest with agitation, we want to get to the reason why. So we're, as emergency physicians, we both diagnose and treat simultaneously. And this is one of the sort of bigger tables that are borrowed from some of the work that Maura and others have presented in this work. And there are some very specific geriatric reasons for agitation that we have to think about because they're at higher risk for multiple reasons: polypharmacy, other underlying issues that they may come in for agitation. And these things potentially are life-threatening in of itself if we delay care. So we want to also think a little bit about the underlying reasons and really discovering them and diagnosing them as you're trying to treat at the same time. Now, when we're thinking about de-escalation, in some ways, some of the stuff I would say is common sense, and maybe thinking a little bit about being empathetic as a physician or as a care provider really helps you ground this type of work. The 10 sort of domains that I list here is based on pretty old literature, actually from psychology, that we borrowed to think about ways that you're really creating that rapport, that therapeutic rapport between you as a physician and the patient. And for those that are not familiar, there's actually a set of guidelines called Project Beta, which is the best best practices for treatment of agitation, and it was published in the Western Journal of Emergency Medicine in 2012. And it's a series of 5 articles where they created consensus statements around a number of different topics, including de-escalation. And this is sort of the bread and butter way to think and walk yourself through how you want to consider de-escalation. And really the most important to think about is that de-escalation, even though we call it verbal de-escalation, is really a combination of both verbal and nonverbal techniques. And in fact, when we think about communication, as everyone probably knows, most communication is actually transmitted between humans in the nonverbal way. This is talking about body language, posture, tone, things that are not necessarily the words per se, but how you are perceived and how you convey that meaning through the things that are not through words. And those are actually in some ways more important to think about in de-escalation than the words you say. And I would go further to think a little bit about when you're trying to de-escalate, what are you trying to achieve and how are the individuals and the patients receiving your de-escalation and the way that you talk to them. And this is sort of the thing that I'm trying to convey here, the difference between impact and intent. Our intent may be to get the situation to calm down and get the symptoms controlled. What the patient's perceiving is not necessarily how you're trying to convey your meaning, and it may be they're receiving signals that are different from what you're trying to say. And this is based on the circumstances of how they arrive to the emergency department, maybe your interaction, how they perceive the things that you're saying, or maybe the way that you relate to the patient, and maybe their prior experiences in the emergency department, and maybe underlying metabolic issues that are going on. And so really not thinking about de-escalation, not necessarily about what you're trying to do, but the relationship and the dynamic that you are creating between you and that patient, and also the circumstances around you are really vital to thinking about how you deliver de-escalation. And related to that is a sense to sort of shift the way we think about de-escalation from not necessarily about what the patient and themselves are happening, but how is the relationship building and this bi-directional feedback and communication between you and the patient. So for example, thinking a little bit about the circumstances leading to the patient coming in and interacting with you, maybe the color of your skin and the patient's skin, race, sex, gender, and the interpersonal relations between you as a human being, and not necessarily even just as a clinician, and that patient. And this leads into ways that we try to circumvent and minimize some of the ways that we create and worsen psychological trauma for these patients that really are ones that are most underserved and have suffered the most amount of psychological trauma among all populations that we care for in the emergency department. And unfortunately, in studies that we've done across both geriatric patients and also in adult patients, we recognize that certain types and groups and subgroups of individuals are the ones that ultimately potentially get most physically restrained and sedated among even either older adults or within the general population. So here's an example. This is a study that actually Maureen and I and others have just published looking at electronic health record data and looking at rates of sedation and restraint for patients that are agitated. And we looked specifically at the older adults, so age 65 and greater, looking across a large healthcare system in the Northeast United States. And just within the older adult population, we recognized that those with Black race, Hispanic or Latino ethnicity are at about 1.2 to 1.3 times higher odds of being sedated and or restrained, despite the reasons they may be coming in or controlling for other factors. And the other thing is, as age increases in this population, so those that are in deciles above age 65, the risk actually increases. And the ones that are 95 years old or higher actually have the highest risk of getting sedated and restrained compared to the younger older adult population, which in some ways, contrary to what we think should be done, right? The older adults have probably the highest risk of being injured. And unfortunately, they're the ones that are getting the most restrained. And so these are ways to think back to what I mentioned earlier about thinking about perceiving how the patients are thinking about their visit to the emergency department and thinking through other structural forces that are leading them to come in terms of how you engage and de-escalate these individuals. So talking specifically about older adults and what strategies may potentially work better for you in terms of de-escalation, these are a couple of things that I've listed here to think about that may help you. And it's really trying to minimize harm and maximizing your chance of success. It's a little bit thinking about sort of the high risk, low frequency things that we do a lot in emergency medicine. We think about intubation, we think about really difficult procedures that are done. And I would say this is just as much of a high risk and low frequency thing as we do in any other procedure. So identify the most qualified person to be able to do this, maximize your chance of success by focusing on needs and reducing stimulation, hoping to do things that are less coercive. Can you talk the patient into receiving all volunteer or or oral medications. And we're thinking about things that are really behavioral and get into the underlying factors for why the patient's agitated. So can you treat underlying symptoms like pain or other things that are causing the agitation? Can you restart home medications that they're already on for behavioral issues to prevent that from happening? And thinking about prevention steps early in advance, like I mentioned, before agitation even develops, as soon as they hit the door in an emergency department, and doing things that are really comfort focused, like getting them potentially into a recliner or hospital style bed rather than being a gurney, which helps basically with mobility and making sure that they don't potentially have increased fall risk. Things that are sort of intuitive that you would think would happen preemptively might help you in this case. And finally, as a transition to workplace violence, recognizing that sometimes de-escalation is not necessarily the right strategy once things fail. So if you're not seeing the level of agitation decrease, or you're seeing things escalate, or if there's imminent damage to property or harm to yourself or others, that really at that point, de-escalation is no longer the strategy you should take, and that you should be a little bit more thinking about means that to try to decrease that danger right at that moment. So transitioning on to workplace violence. So a couple of things to think about, just want to be mindful of time. Okay, I think we're doing okay. That are hopefully linked with agitation and de-escalation, and recognizing that the staff member is sort of this dyad, this partner in this process of agitation management, and making sure that we also stay safe. So things that may already be intuitive and things that us probably as emergency physicians recognize day-to-day working is that healthcare is a particularly high risk environment for injury to us. And if we talk about workplace violence, we talk about 4 types of workplace violence. The one that we recognize the most often is what we call type 2 workplace violence, which is the type of violence that is perpetrated by the patient that we're caring for directly to the staff that's caring for them. So it's someone that's in the emergency department that we're caring for, and it's harming us directly. And as you can see here in this graphic, if we're really talking about workplace violence injuries and illnesses and days from work, you can see that this healthcare industry basically dominates these bar graphs. And it's really sad and unfortunate that this is the world we live in, but it's something we recognize and that we really should proactively work on as we're thinking about agitation symptoms. And I just want to highlight a couple of strategies that has growing evidence and things that we're working on at a national level and that other experts in other domains have recommended as things we need to get done. So, for example, the VA is one of the leaders in workplace violence prevention and thinking about mental health emergencies. And these are just some of the strategies that they've highlighted before. Really, what has shown to work the best is a program of multimodal strategies, meaning things that work in isolation probably are not going to be effective, but bringing in things holistically and thinking about managing workplace violence across a number of domains is really what's effective. Both bringing management and administration in and linking that and communicating back to the frontline employees that are working and really maximizing the amount of reporting that's going on to try to identify and detect these early and to try to work on them preemptively. So a couple of things that I would advocate as being patient-centered. One is a patient care plan. And we do this for many other types of illnesses and diseases, sickle cell care plans and things that really are thinking about creating strategies before they happen. And so can we potentially do the same thing for behavioral health patients? And this, in my sense, is something that I think makes the most sense in terms of patient-centeredness. Can we engage with the individual before these agitation symptoms happen and work with either care providers, visitors, people that they care for, and the patients themselves to say, when you become agitated, what are particular things that really work for you and that we can tailor for you? And it might be different and unique for each individual patient. It may be, I get really agitated if my sister comes during this particular time, or it may be a particular medication has really worked well for me, or it may be a particular location in the department that has been a trigger for us. And so I think really working towards the patient and partnering with them in advance is something that I think makes a lot of sense to prevent it from happening so that the clinicians at the moment in time don't have to recreate that, but can refer to the care plan and be able to reference it in that time of need. And then thinking about prediction tools as well. And these are a list of different prediction tools that have been designed to predict behavior. For example, at our shop at Yale New Haven, we have adopted the Broset Violence Checklist is something that we fill out for each patient. Apparently it's very expensive, and this is something we have adopted system-wide, but it does then create levels of potential violence for each patient and baseline data so that you have ways to track and potentially highlight and predict violence for individual patients. Staff training is something that we talk about a lot, and a lot of hospitals mandate training. I would advocate that in the emergency department, because we work as teams, that we need to also train as teams. And this is not just within the clinical domain, but working with our security and protective services staff preemptively to learn how they recognize safety and violence, and also educating together to understand why we make certain decisions around certain patients, and also working with our allied health professionals. And they're the ones sometimes that de-escalate the most and have resources that we don't necessarily have access to, and that we can come together as a team and train together so that we work together in real life. And so this is something, for example, we've done at New Haven, where we created a code response team, which a lot of hospitals have already done in many different domains, both in the inpatient setting and the ED setting. And this is something that's really about a structured response where we bring our staff together and respond together so that we have safety and clinical management aligned at the same time when these agitation symptoms happen. And finally, broadening our scope of managing agitation is something that I would advocate for. So, for example, in the state of Connecticut, both our group here at Yale New Haven and also at the University of Connecticut have started introducing peer support workers in the emergency department to work with patients with behavioral health needs. And some of this has already been done a lot in the substance use world, but we started to dabble that within the mental health world so that we bring people with lived experience to work with us, both as a way for them to mediate between the things that we need to get done with the patient, but also as a way to really offload some of the work from us to folks that really do it better than we do. They get specified training and specific training on de-escalation. Not that that's something we don't need to do as a core skill, but working alongside us, just like we do for other services that we have in the emergency department. I have a slide for questions, but I think instead of that, I'll turn it over tomorrow.
Yeah, that sounds great. Thanks so much, Ambrose. Yeah, I have a lot of questions too. I sure definitely with the audience as well, but maybe just we can have Dr. Kennedy kind of like take the baton and then we kind of circle back from there. Thanks again.
Awesome. Thank you so much. So I really appreciate the opportunity to talk to this group. It is fabulous to see the cross-pollination between those who are more focused in the psychiatric part of care and those of us that are focused in the geriatrics, and really sharing best practices between each other is amazing. So kudos to the group that brought this together, and thank you for inviting me. I'm going to dig in a little bit more deep on the geriatric syndromes of delirium and dementia. But I wanted to just sort of, going off of what Ambrose said, there are a lot of things that can cause agitation among both young and older adults. And older adults, like young individuals, have issues with substance use, intoxication, and also maybe psychiatric conditions that may be driving their agitation. I'm going to focus on more geriatric syndromes, but just want to acknowledge that, especially as people are living longer with mental health issues, including schizophrenia and bipolar, we need to make sure that we're addressing the right underlying cause of the agitation. So most of you have probably seen this in medical school. You probably hate the fact that I'm putting this table up because you've seen it so many times. Delirium and dementia, I understand it. And most of what we've been taught is really how to distinguish between delirium and dementia when we're either following people longitudinally on inpatient or outpatient setting, or when we have someone there to give us information about the patient's baseline. The reality is, in the emergency department, we often do not have collateral information. And ideally, we are not following people longitudinally, though that has changed in recent years with our boarding crisis. So when I think about distinguishing delirium and dementia, I'm really actually focusing on attentiveness. Does the patient have inattention, or is their attention intact? And typically inattention is a hallmark of delirium. In dementia, it's usually preserved until end stage. I'm interested in level of awareness or consciousness. We see either diminished consciousness or agitation in delirium, but typically in dementia, with the exception of the psychiatric symptoms of dementia, which I'll talk about, this is usually intact in dementia. Speech can be really disorganized and incoherent in delirium, but among people with dementia, it's usually ordered. Towards later stages of dementia, people may be more aphasic, but not disorganized and incoherent. And then hallucinations are common in delirium, and they're rare in dementia until end-stage dementia, with the exception of Lewy body dementia. So if you have undifferentiated altered mental status in an older adult in your emergency department, and they're hallucinating, and the family has no recognition that they have a cognitive impairment, there's no documentation on that. In my mind, that's delirium until proven otherwise. And then the sleep-wake pattern is really disrupted in delirium, which is something we see at 3 o'clock in the morning in our emergency department. So delirium is really this disorder of attention, whereas dementia is more of a disorder of cognition. So most of what you probably want to talk about is hyperactive delirium, and I'll get into that, but I want to look at delirium more as a whole. Just bringing your awareness to the fact that delirium is so common in our older adults. 15% of older adults in your emergency department have delirium. More will probably develop delirium while being in your ED, but the prevalence of delirium in older adults arriving in your ED is 15%. We miss this diagnosis 2/3 of the time, and we actually discharge a good proportion of people with delirium. And delirium is associated with higher mortality. So we have a common condition, we're missing it, we're discharging a lot of these patients, and it's potentially deadly. Some of these patients should be discharged as long as you know, and you know that it's safe to discharge them. But we have to really be more attentive to delirium in our older patients. And I will focus on the hyperactive side, but just a plug for hypoactive delirium. The vast majority of delirium in the emergency department is the hypoactive subtype. This is the patient that is sleeping, not eating, not yelling, not asking for anything, and makes it really easy for us as physicians and our nurses to frankly ignore them. And our attention is drawn to the hyperactive patients because they are agitated, because they are hyperverbal, because they're trying to get out of the bed, because they're interfering with the care that we're trying to provide to them or with others. But it is really important that you are aware that hyperactive is the minority of delirium that we see. And so I will tell you, if you have an older person that's been in your emergency department for hours on end, they haven't complained yet, they haven't asked for an update, they haven't asked when they're going to get a bed or what the CT result was, you should be worried about hypoactive delirium in that individual. So you have an older adult, they're delirious and they're very agitated. What do you give to them to make them better and to treat the delirium? The reality is antipsychotics and sedatives are not indicated for the routine treatment of delirium. And I think that's a really important message. And the recent revision of the American Psychiatric Association guidelines on delirium reinforces this. Outside of alcohol withdrawal, outside of the ICU, antipsychotic and sedatives don't alter the duration or severity of delirium. They don't alter mortality associated with delirium. They don't prevent delirium, and they may actually convert hyperactive to hypoactive delirium, which might sound good to us, right? Because you have this hyperactive patient that's now calm. But there's some studies that suggest hypoactive delirium is associated with higher mortality than hyperactive delirium. So really, antipsychotic sedatives are reserved for those who are at risk of harming self and others, those really severely agitated and potentially violent patients. So if you're reaching for an antipsychotic or a sedative for a patient who has delirium, I would take a pause and just ask a couple of questions. Are you trying to treat the delirium? And is that the reason that you're giving the medication? And if so, I'd say stop. There's no indication for these routinely to treat delirium. If you're trying to sedate the patient, that's a longer conversation. Why are you trying to sedate the patient? And there are times that that's appropriate, but taking that pause and asking those two questions. Because the treatment for delirium is identifying and treating the underlying cause, as Ambrose mentioned earlier. I spend most of my time on dementia because I think this is an area that we don't really think about as physicians. And a lot of what I've learned about managing agitation in persons with dementia has come from either my nursing colleagues who have taught me or care partners of persons with dementia or geriatricians. Nothing that I got in medical school or residency really prepared me to care for persons with dementia. And people with dementia, 7 million or over 6 million people in the US right now have Alzheimer's dementia, one type of dementia. So a huge number of people living with dementia. With the aging of our population, that will continue to grow. If you look at people who are 85 plus, 1 in 3 have dementia. So very, very common in our community, and particularly in older adults. And I wonder if that's the signal that Ambrose was seeing, where those who are older were more likely to be restrained. Is that a reflection of agitation, or is that actually just a reflection of dementia as we age? So common to have older adults with dementia in your emergency department, even more common to have them agitated. So 90% of people living with dementia have one or more of these behavioral and psychiatric symptoms of dementia. Anxiety is the most common. Wandering is a very common behavior where older adults will get up and leave. But agitation, delusions, hallucinations, and aggression are not uncommon, particularly at later stages of dementia. These psychiatric symptoms of dementia are associated with later stages of dementia, decline in functional abilities, which I think is really important to understand. Someone who is really aggressive or has hallucinations probably has less of ability to do their activities of daily living and are more reliant on others for care. It's associated with increased caregiver burden, which I think is not surprising, and unfortunately also associated with a risk for abuse and neglect. So what triggers this? So common triggers for this in patients with dementia: a change in routine, a new environment, or environmental noise, which is pretty much us, right? Our emergency department is the perfect setup for someone with dementia to develop agitation. So one of the things that you can think about, if feasible, I know it's very hard in our emergency departments these days with the capacity crisis that we're dealing with, is trying to create an environment so that it is less stimulating, less noise, and where it is more comforting and less likely to actually result in agitation in the first place. Unfortunately, I think a lot of us sort of approach moderate agitation in someone with dementia this way. It's a problem, and it is. Like, they're pulling out IVs, they're taking off their monitoring, maybe trying to get out of bed when they've just had a hip fracture, and that's dangerous. And so we use restraints and we use medications to try and prevent the harm that might happen if we don't treat it. But I would love for everyone to take a step back. This won't work with everyone, but this will work with some. Take a step back and just think about what someone is communicating to us. And a dementia-informed approach would really be thinking about what is the person communicating with their agitation, thinking about unmet needs, thinking about pain, thinking about fear and anxiety. And in someone with intact cognition, you may be able to elicit this by asking people. But as dementia progresses, it may be harder for someone to actually put forth what is bothering them and what is upsetting them. And we need to try and figure out how to interpret that. Can be challenging, but not impossible. Just like delirium, you want to treat the underlying cause if you can figure that out, and then provide reassurance and redirection. And so I just wanted to spend a minute on this because this again came out of education that I had from nurses, from occupational therapists, and others. I really never thought of agitation as pure communication. And it took me a little while to understand this piece. We all know that dementia impacts memory. I think that's very easy to know. It impacts so many other aspects of cognition. It impacts language. It can impact reasoning and judgment and behavioral control. It can impact physical function and then hearing and speech and vision. It all depends on the type of dementia and the stage of dementia. And certain dementias, like frontotemporal dementia, are particularly associated with agitation and behavioral disruptions because of the areas of the brain affected. And so you take someone who has dementia, which has impacted their physical abilities. They may have a harder time doing things for themselves, be it shifting in the bed to get comfortable, or getting to the bathroom, or feeding themselves. And they have some challenges with communication, with language and speech. And as a result of the accumulation of those two things, they have a high risk to have unmet needs. And you add in issues around behavioral control impacted by dementia, and that results in agitation, really just to communicate basic needs and get them fulfilled, as well as to communicate emotions. If you add the emergency department to it, it just worsens this cycle. Right? In the emergency department, it's even harder for someone to actually do their activities of daily living. Someone who at home could toilet themselves and feed themselves may not recognize a tray with a dome on it as being food, certainly wouldn't know how to get out of the bed and find a bathroom and utilize that bathroom. And it's hard to communicate with us in the emergency department. We're busy. It's really hard to find someone to flag someone down. And even if someone does a great job of giving someone the call bell and telling them to press that little red button with the nurse on it, if someone has dementia, they may not recall that instruction. And it can be really hard for them to figure out who to communicate their needs to if they're able to communicate it. So again, sort of in the non-violent, not severely agitated patient, taking a step back, taking a minute to think about what they might be trying to communicate to you, trying to address the need that might be there. Are they hungry? Are they thirsty? Have they not urinated recently? Do they need to go to the bathroom? Have they been in that stretcher for a really long time and are just sore and need to walk? Do they have pain, which we haven't treated yet? Is the environment overstimulating? Can we address that? Or is it more of an emotional concern and helping to support that? So treating that cause, providing reassurance, and providing redirection. So if you're someone who likes little fancy mnemonics, I would like you to move away from the B52s in geriatric patients. You should never give Benadryl, and we should never give these doses in geriatric patients. But I really love this mnemonic of TADA. So this came out of this gentleman named Flaherty. He developed it for delirium. I think it works for dementia as well. And honestly, it works for a lot of people with cognitive impairment, so traumatic brain injury, neurodivergent individuals. Tolerate behaviors that are not dangerous and provide redirection. If someone's pulling out an IV, they don't necessarily need restraints. They don't necessarily need medications. They need that IV covered, and they need a way to redirect that fidgeting behavior. Anticipate their needs, and meet them. So particularly with people boarding in the emergency department for a very long time, thinking about helping to make sure that they get food, helping to make sure that we are regularly toileting patients, not something as physicians we often think about, but something that we probably need to be supporting our nurses in and our aides in and paying attention to. Don't agitate. So limit catheters if they're not needed, limit restraints that are not needed. And one thing that I put under this as a don't agitate is not to reorient. And I think this is one area where the sort of principles of de-escalation I might disagree with in someone with dementia or active delirium. And we talk about like agreeing to disagree in those circumstances. And I think that works fine in someone who is cognitively intact. But someone who is right now either a fixed or a current state of disorientation, someone, for instance, who thinks that it's 1974 and that they're in high school, if you try and challenge their fixed reality and tell them it's 2024 and they're a grandmother and they're wrong, that honestly is probably just going to drive more agitation. It's better to sort of just redirect that conversation. So someone says they're really worried about getting home because their mom will worry about them. They're supposed to be home at 5 every day. Just sort of say, oh, what sort of things do you enjoy doing at school? And just redirect that conversation instead of saying, no, 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 you're 80. Sorry, you're not in high school. That's going to drive more agitation. And that's a slight variation that I have in terms of those general de-escalation techniques. And these are some things that I have in my emergency department on the right-hand side and some additional things on the left-hand side from other emergency departments that can be really helpful for reassurance or redirection. So fidgeting behaviors, and I have one of these at my bed. Oh, I put it here. Fidgeting behaviors. I probably was using this earlier during this talk. We have these little like tangles that can redirect that. Lauren Sutherland, who's at the Ohio State, will put those little sleeves over the IV and then put fake IVs over them to give something for someone to fidget with. You can have very simple sensory stimulation. So glow eggs, this is one of them, or music as a way for calming, as well as just redirection tools like doing a word search or folding towels or even baby doll therapy can be an effective way in mild to moderate agitation. It is really wonderful if someone has a plan. We have a great occupational therapist here who has created plans like Ambrose was talking about for our patients with autism. That is really helpful to follow. And I think this is a great opportunity for people with dementia to create plans for de-escalation and therapies that are effective. Sometimes you do have to give medications. And just like when you're thinking about antibiotics for someone with an infection, you need to pause and think about a few things when you're thinking about giving medications for agitation in geriatric patients. The indication, right? So if someone's got an infection, you want to think about what is, if it's a skin soft tissue, you're thinking more gram-positive organisms. If it's a GI infection, you're going to sort of choose a different antibiotic. So the indication. Pain, are you trying to get an emergent procedure or emergent imaging done? Or is this really behavioral management and someone's got pretty moderate to severe agitation and other methods aren't successful? Obviously, oral versus parenteral. Hopefully in severe agitation, you're probably not going oral, you're probably going more parenteral. In older adults in particular, you need to think about Parkinson's disease and Lewy body dementia because of differential risks with antipsychotics, and then obviously allergies. So there's a JSAP open article that we published a little while back around agitation in older adults, and I've revised it slightly for this. The first thing I would encourage you to do in an undifferentiated agitated older adult is to bring your ultrasound to the room and make sure they're not having urinary retention. We actually had a fairly recent case at my institution where the clinicians were absolutely spot on. They did a really good exam. They recognized the patient had really bad abdominal pain, and they wanted to get a CAT scan because they were really concerned that they had like a perforated diverticulitis, and spent a lot of time trying to sedate the patient to get the imaging needed. And between issues with getting the CT scan and imaging for the CT scan and just general delays, it took 9 hours to get that CT back. And it turned out the patient had urinary retention. And I've seen this time and time again. This isn't just this one patient at my institution. Urinary retention is a common cause of agitation in geriatric patients. You can diagnose it with your ultrasound. So agitated geriatric patient, bring your ultrasound, do your POCUS. Outside of that, is there another painful condition? We often see agitation in persons with dementia with hip fractures. So really think about analgesia for the patients with painful conditions acutely or with chronic painful conditions if they're with us for a period of time, needing to continue those medications. I'm a little bit controversial. If all I'm doing is sedating someone for critical imaging, and that's the only reason that I'm giving medications, I do tend to give sedatives, short-acting sedatives, to get them through the critical procedure or critical imaging. This is a little controversial because people are worried about delirium from benzodiazepines, but I've also seen so many people get multiple doses of antipsychotics for the sole reason of a CT or an MRI, and 5 doses of an antipsychotic is probably more harmful than 1 dose of a sedative. In Parkinson's disease and Lewy body dementia, quetiapine is probably your go-to for oral medications. And then for parenteral, I tend to think about benzodiazepines. Some people will talk about olanzapine. There's some risk factors there. It has a long half-life, so multiple doses of that can be challenging. And then beyond that, I usually am going for a second generation antipsychotic. So many people still prefer haloperidol, particularly for delirium. But the key thing is knowing your geriatric doses. You want to start low. It's a lower dose than your non-geriatric patients, and go slow. And remember the time of onset. And again, I'm not going to go into this table. This is in the JSEP Open. A few things just to note. Your IV dose for an older adult is 0.5 to 1 milligram of Haldol, not 5 milligrams. And if you're giving haloperidol IM, the time of onset is 20 to 60 minutes. I think that's a big mistake we often make. And olanzapine may be a good drug in severe agitation in some people. It does have a long half-life, and just to be aware of that if you're giving multiple doses. This is another great on-shift resource. This is the ADEPT tool. You can get it online, acep.org/ADEPT, or if you're part of ACEP, it's one of the tools in their point of care app. But it has, in addition, some general strategies, geriatric specific dosing, so you don't have to memorize it all. And the last point that I just want to talk about is leveraging caregivers. For a long time, in the early stages of the pandemic, we excluded caregivers of persons with cognitive impairment from the ED under the no caregiver policy. They're not they're not visitors, they're caregivers. And they really can help redirect, comfort, reorient our patients. They can also help us interpret some of those agitation and understand what's going on with the patient. So really encourage you, if family and caregivers are at the bedside, encourage them to stay and leverage their expertise, because they can really help you in the de-escalation. And I will leave it at that.
Great. Thank you so much, Mara. That was wonderful. It's so wonderful to see both presentations together, and basically just the similarities and stress on communication and unmet needs, basic unmet needs in both presentations, and that overlap was so wonderful. Thank you both. I know I have questions and would love to sort of see if we could start with some focused questions for me and Bernard Chang, and then we can open it up to the group and then go from there.
Yeah, that sounds great. I mean, I can start right now too. I mean, it's interesting, Maura, kind of your last point with regards to caregivers and the involvement from there. I mean, just speaking anecdotally, some of the work that we do here at Columbia, as we've been looking at post-traumatic stress symptoms, or PTSD, following patients with ischemic stroke and acute coronary syndrome. And during the pandemic, similar to other hospitals, we kind of restricted the number of visitors into the hospital. And just incidentally, we were kind of collecting data on prevalence of PTSD following stroke. And we actually saw a significant increase kind of from that. And we kind of, after doing all our post hoc analysis, it was really kind of like this other variable, the impact of having family members or kind of other caregivers kind of around that presence, really kind of almost accelerating some of the psychological distress that some of our patients were experiencing. And so my question is just around that framework. How can we, any suggestions or tips of how do we kind of frame that the caregivers or those other allies kind of with those patients to kind of really leverage that kind of local expertise to kind of help patients in the emergency department setting? How do we kind of build on their local expertise to really help those patients kind of as they're being evaluated in the ED setting?
Yeah, so I think first of all is just making sure that your department acknowledges the difference between a caregiver and a visitor. And so we had to do a lot of reframing of that during the pandemic and emphasizing cognitive impairment as a disability. And I think people kept just seeing caregivers as being nice but not necessary. And we kept reinforcing that this individual has a disability and we need to accommodate the disability. The other place where, if you're trying to convince an organization to create a formal policy, is also a lot of these individuals are surrogate decision makers, and having them at the bedside is really really critical for that management. It is worth noting that sometimes, unfortunately, family members can make things worse. And I had one person that I cared for whose daughter on the phone said, I wish I could come in, but I trigger my mother and my husband's going to come in because she gets really angry when I'm nearby. And so we just know, as sad as it is, I can't be there. But you can ask things. For instance, what does the person want to be called? What are things that they're interested in? If they can stay at the bedside and we can support that, we should really be doing that. But that's also a lot to ask on someone who probably has a lot of caregiver burden. So simple things like thinking about what might be triggering the patient and how can we de-escalate it. And there was one patient who came in, and I happened to get the phone call from the family, and I was like, well, what can we do that would really help, like de-escalate or make the person more calm? And she told me that, in her younger years, she was an architect. And she loved architecture. And she often carried with her pictures of buildings and architectural plans. And I was going off shift, but I sent this on to the team that was coming off shift. And I got an email the next day that they had been called to the room. There were 4 security officers, 2 nurses, and this PA had walked into the room with this escalated environment. And she was trying to leave and was angry. And he was like, how do I implement what Maura just told me? I'm just going to have to medicate this patient. And then he saw a binder that was on her bed. And he just sort of had people take a couple steps back and he said, what's that on your bed? And she's like, oh, yeah, it's pictures. And he's like, could you show me a few? And so she got back into bed and she picked it up and they put the railings up and she started going through and they were all able to leave. Is that going to work in every case? Absolutely not. But if a caregiver is there or by telephone, being able to understand what is triggering, or importantly, what is calming, and seeing if you can create that, I think is a really important approach.
Yeah, that's terrific. Thank you so much.
I was just going to add to your point, Maura. I think part of the challenge of having caregivers at the bedside, or maybe families and visitors, is thinking about the workload and the impact on your staff, which you hinted at in your presentation too. Because I feel like the conversations I had with staff who either trained or came up during COVID is that they are somewhat used to not having visitors and sort of framing it around, oh, it's so much easier when family weren't there because it in some ways decreases the workload. They didn't have to manage expectations of the family member. Sometimes they feel like they had to explain certain things or the family members might interrupt them because they're asking questions or doing things, and they view that as an added burden, which I think we do have to recognize as physicians. We are at the bedside a lot less than the nursing staff or our residents, and they're the ones that have to spend more time at the bedside explaining and doing things. And I think maybe doing some preemptive sort of huddling with the nurse, maybe when they're in the room with me and the care provider, and saying, hey, we recognize that your family member is at risk for delirium or agitation, and to try to make it easier for the patient stay, but also for the nurse to have to work with you, let's talk about how we want to work as a team and maybe involving the caregiver in that conversation if the caregiver is either enabled or interested to involve, and then listening to the nurse's needs as well, I think will set your chance of success so that you're not sort of adding additional burden. Or is there something as a physician that I can do to help offload that so that we make that experience better for the patient? So like if the caregiver or something, maybe direct them towards me and I can answer some questions to help offload help from the nurse. For example, just thinking about that teamwork aspect, I think is important, and maybe involving the caregiver as part of that team.
Yeah, and I would also just outright in that team huddle acknowledge that someone with more advanced dementia can actually may not be able to communicate their needs, and that family member actually is critical to providing that information. And so it may seem like they're sort of flagging them down and creating increased workload. They're actually trying to provide the communication that, say, if I was in pain, I might be able to do myself. And I just want to flag that for individuals who don't speak English or who don't speak the language of the clinicians that are providing care, I think they're probably at some of the greatest risk of not having their needs met and their pain adequately managed. And some work by Anita Cherry interviewing caregivers of persons with dementia really talked about how they felt like they constantly had to advocate for their family member and flag down family members just for simple things like their family member was vomiting and trying to get that treated because the person with dementia has a hard time communicating. So I think just even like in our huddles, acknowledging that cognition impacts communication and that's what that family member may be trying to do is really bridge that communication gap and serve as someone who can provide the communication.
Great. Thank you. I have a quick comment and just question for Mara specifically. I think it's such an important conversation to discuss, like in general, how you broke it down, the why behind the agitation, but then the why behind the sedation at that point, and kind of at what point mindfully thinking about it, and how the mnemonic could be used for any form of agitation, whether it's underlying psych, dementia, delirium, or even trauma as a cause of the agitation. But then thinking specifically about agitation and then the level of point of no return, at which point patient or staff is safety is at risk, and then whether you need to facilitate an emergent scan and those particular subsets of circumstances. I know that you referenced your paper, the JSTEP Open. I know that I often use that algorithm when I'm looking at those situations where I'm kind of thinking about then to facilitate an emergent scan. And I'm just curious at this point, kind of what people are using in general for. I feel like with benzodiazepines being sometimes the not great, but then you were talking about how in general how that can sometimes be the only thing at that point that's going to facilitate the scan and prevent further harm, and whether Ativan or Versed. It's just sort of an interesting conversation of what people are really using, and there may not be no answer of what's the safest in those situations, but thinking about the duration of action. And I know is in the algorithm, but I've often, if I have to, sometimes I'll do one of Versed because of the shorter duration time, but I try to avoid it whenever possible. But it's just sort of something I've been thinking about in those situations.
Yeah, a lot of studies that looked at management of agitation in the emergency department have excluded older adults. And a lot of research excludes those with limited decision-making capacity, such as those with dementia. So whether it's an explicit exclusion or just a de facto exclusion based on sort of inability to get consent, we don't have good research into exactly how best to manage undifferentiated or even differentiated agitation among older adults. And so again, if the takeaway is make sure they're not in your urinary retention. If they have pain, treat their pain before you give them an antipsychotic. I think those are two great things to do. The sedation for imaging, if the only reason this person needs imaging, that's my personal take, having reviewed so many quality and safety reports on 5 doses of an antipsychotic, and the sole reason was a head CT. But there's ways to get that imaging without antipsychotics. I've had family members go into X-ray and CT with patients and being able to calm them through that. My light orb got one patient through a CT that no one thought would happen. But sometimes medications, and often medications, are indicated in that severe agitation piece. I will go to low dose Versed as a really quick one. And I had everyone thought I was going to end up admitting because it was, head injury, anticoagulation coming from a sniff. He was agitated, and they looked at me as if I had 4 heads when I gave Versed. He got the head CT, was sedated enough for the lac repair, came to, and the sniff took him back. And in 5 hours, we had a head CT, a lac repair, and an ambulance transport back to his sniff. And he was back to his baseline chatting and totally cooperative with us. And I think that's because I chose 1 dose of a sedative to get him through the critical parts. And I think it would have been a much longer period of time had we had tried antipsychotics for their sedative effects.
And I would just add that I think what Maura said earlier during the presentation is key around dosing, to really be cautious about starting lower for older adults. And then my pharmacy colleagues have told me that thinking about route is important as well, because actually IV Ativan is actually quicker onset than IV Versed. It's really 1 to 2 minutes, and Versed takes a little while longer to act, but Versed lasts shorter. And so there's a little bit of a trade-off there. So you kind of have to make that judgment call, whereas intramuscularly, Versed actually works faster than Ativan. Ativan takes about 15 to 30 minutes to work. So it depends a little bit on what's at your disposal and your ultimate objective and how long you need the patient potentially be sedated for.
Well, I want to make sure we have time for, thank you so much for the wonderful responses. We want to make sure we open it up to the group as well. So if anyone has any other questions, please feel free to, before we run out of time. And if you have questions you'd rather message in the chat, please feel free as well.
That's great. Well, I think we are at the hour right now, but we just really want to thank everyone again, particularly to Ambrose and Maura, for kind of giving some really great kind of discussion and introduction to the group. I think it was extraordinarily useful and very high yield for a lot of our members. So thank you so much. And Surya, I don't know if you have any other last words you wanted to say before we kind of adjourn the meeting.
Yes, I just want to thank everyone so much for joining this webinar. And thank you, Dr. Kennedy, Dr. Wong, for being our first speakers of this very important topic. Thanks, Dr. Chang, for co-moderating. We hope to continue this collaborative webinar series, and we're very curious as well if anyone has topics that they're interested in hearing about. Like I mentioned before, loneliness, social isolation, depression, and suicide screening, substance abuse, but there's many more people are probably interested in, so please let us know. This was a co-sponsored webinar, so if you're interested in joining AGIM, we have the information here. You can contact myself or the president, Dr. Catherine Buck. And then also if you're interested in joining the Behavioral and Psychological Interest Group of SAEM, you can contact Bernard Chang or Michael Wilson, the incoming chair of the group. And we're very excited that you guys joined us. Thank you so much for everyone involved.
Thank you very much.
Thanks again, everyone. Have a great afternoon.